So continue on my presentation talking about update management of cancer-associated thrombosis. As you know, this is a very important topic. It's very common, it's very challenging for oncologists and thrombologists and hematologists. My objectives gonna be current state of cancer-associated thrombosis management in clinical practice, and DUACs, clinical data in cancer-associated thrombosis and clinical implication. So I'm gonna navigate you through my outlines. So we'll take you one by one. First, starting about CAT or cancer-associated epidemiology. VT in patient with active cancer is common and associated with high recurrence and mortality rate, and the risk of VTE is up to 50-fold. It's ranging from 7 to 50-fold higher in patient with cancer compared without cancer. And about 15% of patients with cancer experience one or more episodes of VTE during the course of their disease. And about 20% of patients with VTE have cancer at the time of presentation of VTE. So this is a common disease. If you have 100 patients with venous thromboembolism, about 20% are attributed to malignancy. Gonna discuss what's the historical perspective of Trousseau syndrome. It's named. I mean, cancer-associated thrombosis. It's named after the scientist, clinician, Professor Trousseau from France, Paris in 1865. You can see this is his picture along with his resident and fellows, and he was working in Hospital Hotel Dieu in Paris, 1855. So interestingly, we call Trousseau's syndrome as a thrombolytis, a thrombophlebitis migrans, or migratory thrombophlebitis. So this is, I'm quoting his, statement, his words. There appears to be in cancer a particular condition of the blood that predisposes to spontaneous coagulation. This is February 1865. He died, about next year, 6 months after this statement. So he said, Peter, I'm lost for the phlebitis that has just declared itself tonight leaves me no doubt about the nature of my illness. This is about January 1867. This is, he died 6 months later of gastric cancer. So what we have is migratory thrombophlebitis. Like this is, if you can see, this is a patient with a DVT, classical presentation of DVT, and this is, as you see, this is the upper limb. This is the vein, inflamed vein with erythema, and usually hot, tender, and cord-like. So this is thrombophlebitis. Usually it is a migratory, so you can start here, then move to the legs. So this is one of the paraneoplastic presentation of malignancy. And he gave, lecture, in 1865. He said, when you are undecided about the nature of the disease of the stomach, like you have abdominal pain, when you hesitate among a chronic, you are confused between chronic gastritis or simple ulcer or carcinoma, aphlegmasia albadolens occurring in the leg or arm will put an end to your indecision, and you will be able to assert positively that a cancer is present. Further, this obliterative phlebitis does not pertain exclusively to carcinoma of the stomach, and it may occur with a cancer affecting any internal organ, whatever. So this is, he's the first, one who pointed out to cancer-associated thrombosis, Trousseau syndrome. What are the risk? What are the risk factor of cancer-associated thrombosis? So I will summarize it in this, slide. So we divide it to either it is, a risk factor for cancer-associated thrombosis. Either it is cancer-related, or it could be treatment-related of cancer, like chemotherapy, etc. And it could be patient-related, patient factor, age, comorbidity, family, previous history of VTE, or it could be a biomarker. So starting first with the cancer-related, so it is important, the primary site of malignancy, it matters. Like pancreatic cancer is the most thrombogenic carcinoma. Stage, risk increase with a higher stage like metastatic cancer. The risk, it can increase, as I mentioned, about 50-fold the highest. If you have early stage, it can be 7 to 10-fold. Histology is important. That it's more common in mucin secreting adenocarcinoma. So it is more common in adenocarcinoma than squamous cell carcinoma. Time since diagnosis is important. Risk increase during the first 3 to 6 months. So the first 6 months of diagnosis of malignancy, this is the highest risk of venous thromboembolism. Now I'm going to move to the treatment related. So important chemotherapy and anti-angiogenesis agent is important. Anti-VEGF, important risk factor for cancer-associated thrombosis. Also hormonal therapy, which is used, it's a mainstay treatment of breast cancer, like tamoxifen, radiation therapy, surgery, more than 60 minutes, transfusion also found to be risk factor for VT in cancer patient, indwelling venous access. Then we have patient related factor, age, increasing age, ethnicity, risk increase in African Americans, comorbidities, infection, renal and pulmonary disease, arterial thromboembolism, VT history, inherited thrombophilia, obesity, and performance status. So this is related also performance status. The worst performance status, the highest risk of CAT. So a biomarker, these biomarkers used in clinical prediction models for prognosis for cancer-associated thrombosis, like platelet count more than 350 is a risk factor for CAT, leukocyte count more than 11,000, and anemia hemoglobin less than 10. It's the score, we call it Corona score. So this just to put it in this nice model. So the risk factor for cancer-associated thrombosis, either it's atherosclerosis and VTE history, whether it is personal or family history, primary site, stage, history of histology of malignancy, surgery, trauma, indwelling venous catheter, chemotherapy, anti-angiogenesis agent, hormonal therapy, inflammation, immobility, hereditary and acquired thrombophilia. So this is, it's like, there are interplay between risk factors. So the patient does not have single risk factor. There might be interplay between, like, the cancer histology type, in addition to chemotherapy, obesity, family history of VT. So it is a cumulative, risk factor. And now moving to pathogenesis of cancer-associated thrombosis. So it's very complex, but now it is well established the fact cancer itself is hypercoagulable state. It's associated with a state of hypercoagulation or hypercoagulability, and there are, the suggested pathways in CAT pathogenesis. So it is complex, but remember always the virtue triad. So it can affect the three limbs of the triangle, can affect the endothelial damage, as you see here, the endothelial damage. So this is, remember, the endothelium is very delicate. It's very protective against thrombosis. So what can cause damage to the endothelium? Either you can chemotherapy can cause endothelial damage. The cancer itself, malignant tissue, the invasion of the endothelial tissue. So this is one factor. The other factor, which is the hypercoagulability state, the hypercoagulable state is due to the cancer itself. So the cancer itself secretes, micro particles, can activate the coagulation, cascade through tissue factor. So this is important. In addition, it can activate the inflammatory cytokines. We know there is a strong relationship between infection, inflammation, and cancer. So the cancer, like stimulate pro-inflammatory cytokines like, tumor necrosis factor, interleukin 6, and etc. So what happened that it will activate the monocyte, activate platelet, it activate leukocyte. So that's really important, causing ultimately causing conversion of prothrombin to thrombin that will cause the clot. In addition, we can have, these are the, activated endothelial cells, inflammatory cytokines, and tissue factor containing micro particle. Putting the third arm is the stasis. Usually these patients are hospitalized and undergo surgery so they can have stasis. Very important factor also to mention is the indwelling venous catheter can cause endothelial damage. So as I mentioned, you have inflammation, thrombosis, and tumor. And to put it in this, nice model, Virtue, triad. So the first one, the stasis. Stasis, a prolonged bed rest and or extrinsic compression of blood vessels by tumor. So like you have immobilization, prolonged bed rest, hyperviscosity. They can have dehydration, extrinsic compression. Then you have the endothelial damage, direct invasion by tumor, prolonged use of central venous catheter, and endothelial injury by chemotherapy, anti-angiogenesis drugs, surgery, and radiotherapy. Then you have the hypercoagulability, like tumor-associated procoagulant, and cytokine like tumor tissue factor, tumor necrosis factor, interleukin beta, VEGF, etc., and enhanced selectin integrin mediated adhesive interactions between tumor cells, endothelium, platelet, and macrophages. Now moving to the screening of malignancy in unprovoked venous thromboembolism. So just to know that we have up to 10% of patients who present with unprovoked venous thromboembolism, DVT or BE, they receive a diagnosis of cancer in the year after the diagnosis of VTE. And after that, after like 1 year, the incidence rate of cancer diagnosis gradually declines and returns to the rate in general population after a year. So we know that's why in 10%, it might be the first presentation of VT. It could be a paraneoplastic presentation of cancer. So what's the available data? There is extensive. This topic deserves one talk or webinar. I will summarize it. The available data don't support an extensive search for occult malignancy. However, it's important to pursue symptoms or signs which suggests an underlying malignancy and to ensure that the age-appropriate screening tests have been performed, i.e. like a female patient. So age, gender-appropriate screening for her is a breast like mammogram or breast ultrasound. For a male age, and also we do for her colonoscopy. For a male, for example, you screen for colonoscopy and some patient you might for cancer. So age appropriate cancer screening is important. And this is one study published 2015, one of the landmark study in New England Journal of Medicine, showed there is no difference between extensive workup for cancer-associated thrombosis in idiopathic VTE versus just limited screening. So they found the prevalence of occult cancer was low among patients with a first unprovoked venous thromboembolism. So routine screening with CT. So this is the extensive, they add CT. So routine screening with CT abdomen and pelvis did not provide a clinically significant benefit. So we don't recommend, if you have a patient with presented with unprovoked VTE, you don't need to do extensive. I have seen it. I've seen it in the clinical practice, in the private practice. So patients with unprovoked VTE, they will do extensive, workup, imaging, chest, CT abdomen, pelvis. It's not, is not indicated. The most important, you have to ask about symptoms, signs for malignancy, and you perform age-appropriate gender, cancer screening. And some cases, if indicated, you do for extensive, investigation like CT or MRI. So talking about now moving, just we are escalating, gradually to talk more about the pharmacotherapy. Now we're going to talk about the efficacy and safety of low glucocerebrin versus vitamin K antagonist in the treatment of cancer-associated thrombosis. As you know, until right now, the guideline considering is the standard of care for cancer-associated thrombosis. And I think in the future, you will find paradigm shift, and might be DUAX will be first choice. So talking about, there are many studies compared lumoxibirine versus warfarin vitamin K antagonist. So this is the most famous study, a CLOT study. So they compared dalteparin versus vitamin K antagonist in cancer patient with VTE. And we know dalteparin is the most commonly used lumoxibirine in Canada, and also commonly used in the state. But in Canada, it's number one low molecular heparin. So what they do, they have, this is the design of the study, cancer patient with 2 DVT and or BE. So there was about 676 patients. So divided, to two groups, dalteparin group. So this is a randomized clinical trial. So you have dalteparin group, and you have the dalteparin, over what we call a classical, approach. They overlap dalteparin with vitamin K antagonist warfarin. So interesting, they just, this is across all trials with lumoxibirine for treatment of cancer associated thrombosis. So always they start with the full dose, like 200 unit per kg once daily for 4 weeks. Then they decrease by 25%. So then it will be after 4 weeks, after the first month. So they will continue 150 unit per kg once daily. And like for here, and like we use commonly enoxaparin, the same. If you use enoxaparin, you can use 1 milligram per kg BID for 4 weeks. Then after 4 weeks, you use to 1.5 milligram per kg once daily. This study continued for 6 months. The other arm, it's the classical approach, dalteparin, for 5 to 7 days, plus, vitamin K antagonist, target INR 2 to 3 for 6 months. So duration of this study for 6 months, and the result was impressive. So they found the recurrent VTE was significantly reduced in the dalteparin arm or lumoxibirine arm, and you see the risk reduction about 52%. So 52% there is reduction in the rate of recurrent VTE, and also the major bleeding. It was comparable. If you see, this is the dalteparin lumoxibirine arm. So you have 6 major bleeding and 8 minor. Here you have 4 major, 15 minor. So it was not clinically, significant increase in the major bleeding. So this is with this and other trial, this is Meyer study. They use enoxaparin, Claude, they use dalteparin, Hall, Deitcher, also Catch, they use tenzaparin. All of them, you see, this is like meta-analysis, and you see this is forest plot. You see all showed, significant reduction in the risk of recurrence of VTE, and you have the composite, endpoint. You can see this is about 50%. The combined, endpoint, 50% reduction in the risk of recurrent venous thromboembolism. Also, the bleeding, it was not significantly. You can see across the line of unity, it was not. There was no significant increase in the major bleeding. So, based on this, you know that low multiparine is the standard of care for cancer-associated thrombosis. So, what are the comments about? We know it is effective, it's safe drug, but it is inconvenience for patients. They are cancer patients. They are overwhelmed with the disease burden, chemotherapy, etc., and radiotherapy, and they will add to the burden, to have injectable medication, let's say for 6 months, or some patient longer. So the benefit-risk profile of lumoxibirine for the treatment of patients with cancer thrombosis is not ideal. Is excellent, but not ideal. Although better than the vitamin K antagonist. We know vitamin K antagonist is in patient with cancer patient. There is significant drug interaction. They need to monitor their INR frequently adjust their medication. Even this is more cumbersome. That's why you see higher recurrence of patient, because frequently they interrupt anticoagulant therapy because they are undergoing procedure, line insertion, surgery, etc. Biopsy. So it's not a perfect drug. Lumoxitibarine is better, but we are looking for better options. So lumoxitibarine is associated with considerable burden, cost, and inconvenience for patients, but it's the standard of care still and the most effective and safe drug. But these are the drawbacks. Lumoxitibarine remain the treatment of choice for patients in whom DUACs cannot be given. You have patients like they might have mucositis, they might have problem of intake, patients have absorption, or intolerance of, or they cannot take any oral medication, the chemotherapy, nausea. So if you have significant thrombocytopenia, or you have contraindication because drug-drug interaction with DUAC, there are some list about P-glycoprotein inducer inhibitor and cytochrome enzyme inducer inhibitor. So now talking to move efficacy and safety DUACs. Now we compare DUACs versus lumoxitibarine. This is the state of art in the field of cancer-associated thrombosis. So we'll talk about important two study, Select D for rivaroxaban compared to lumoxitibarine, and the other one, Hokusai cancer comparing edoxaban with lumoxitibarine. Then talk about the most recently published Caravaggio study. They compare apixaban with lumoxitibarine. So this is the clinical pharmacology of oral anticoagulant DUACs and vitamin K antagonists. So as you know, we have factor 10A inhibitors like apixaban, edoxaban, rivaroxaban, and betrixaban. So they inhibit factor 10A, so single, so called factor 10A inhibitor because they are a class of oral anticoagulant. They can inhibit directly factor 10A. And we have direct thrombin inhibitor like dabigatran and directly inhibiting thrombin or 2A. That's why you call direct oral anticoagulant DUAC, we call it. We don't call it any more new oral anticoagulant. Either we call it DUAC or we call it NUAC because non-vitamin K oral anticoagulant. Then we have the warfarin. Warfarin is like hitting, different, key coagulation, proteins in the coagulation cascade. So it can inhibit 2, which is the thrombin, 2, 7, also inhibit 7, warfarin, 2, 7, 2, 7, 9, 10. 2, 7, 9, 10, all inhibited by vitamin K antagonist. This is for warfarin. So compared to the direct oral anticoagulant. So this is the clinical pharmacology for anticoagulant. So you have apixaban, dabigatran, edoxaban, rivaroxaban, and warfarin. So let's say if we compare apixaban with warfarin, so this is direct factor 10 inhibitor mechanism of action for warfarin inhibition of vitamin K dependent glutathione factor like 27910. Oral bioavailability 50%, warfarin 95%. It's not a broad drug for both. It's not affected by food, but warfarin is affected by food high or rich in vitamin K. Very significant, interaction. The renal, this is 27 renal. This is the least renal excreted compared to other DUAC, like see the dabigatran 85% renal excreted, edoxaban about 50%, and rivaroxaban 33%. So warfarin is not renal excrete. That's why used in patients with end-stage renal disease or severe renal insufficiency. So it is the Tmax about 3 to 4 hours. So it's like mimicker of lumoxitibarine. So the onset of action is fast about 2 hours. It can you have the kick of the drug and reach to the peak about 3 to 4 hours. Versus warfarin, you need 3 to 5 days. That's why it needs to be overlapped with rapidly acting anticoagulant. Some patients not only 5 days, 7 days to start to see the onset of action. half-life 12 hour. Here is about 40 days, 40 hours. So talking about Hokusai VTE cancer, edoxaban versus low-molecular heparin. We know edoxaban is direct 10A inhibitor. This is one England Journal of Medicine about 2015. This is the first study showed that DUAC is non-inferior to low-molecular in the treatment of cancer-associated thrombosis. So the design of the study is a probe study design. This is a prospective, open label study, but we have blinded endpoint. So, and yes, it is open label, but adjudication committee, they are blinded to the endpoint. So they have the primary outcome composite of either recurrent VTE or major bleeding. So you can see the enrollment objectively confirmed VTE and cancer. So active or diagnosed in the previous 2 years. And they stratified randomization for bleeding risk and dose of adjustment. So they randomized to 1-to-1 ratio to lomectibarine overlap. This is like classical approach. Lomectibarine overlapped with edoxaban. Like remember the CLUT study, they use here. This is not overlapping. This is they use lomectibarine for 5 days, then they switch. We call it switching approach. Like for the bigatran, the same. So then switching from lomectibarine to edoxaban. However, for the other arm, it is the same deltabarine. They use it 200 unit for the first per kg once daily in the first month, then followed by deltabarine 150 unit. And they have follow up the study up to 12 months. See, let's you find the endpoint for this the recurrent primary outcome, recurrent VT or major bleeding. This is composite, endpoint. They found this study the edoxaban was not inferior to deltabarine. So it really it met the endpoint for inferiority. So it was significant p-value, but was not significant for superiority. So it's not superior. Edoxaban, it is non-inferior to low molecular heparin as composite endpoint of recurrent VT or major bleeding. Also, you can see the recurrence rate is decreased about by 30%. And major bleeding, there was increase in the major bleeding in edoxaban. Also, it was not major, but it was found that this is the first signal that showed us that direct oral anticoagulant DUACs, especially direct 10A inhibitor like edoxaban, increase the risk of gastrointestinal bleeding, upper and lower. You can see comparison between deltabarine. You can see here 6 compared to edoxaban 20, and they mostly upper, about vast majority upper compared to the lower. So as a matter of fact, the DUACs increase the mucosal bleeding. We know increase the mucosal bleeding. Like in female, we do see more menorrhagia, and male menorrhagia or heavy menstruation. In male, we do see hematuria, especially patient if they have like nephrostomy tube or they have kidney stones. Like you have underlying pathology. So it does increase mucosal bleeding, and it's a common, it can commonly cause upper GI bleeding. That's why not surprising if you because these patients they have GI pathology, whether it is esophageal cancer, gastric cancer, or lower GI tract cancer. So it does increase the risk of bleeding in gastrointestinal cancer. So this is the select D study, rivaroxaban versus lumoxitibarine. It's again the same study, prospective randomized open-label multi-center pilot phase 3 study. And the primary outcome was VTE recurrence, and secondary outcome major bleeding and clinically relevant non-major bleeding. I forget to define the major bleeding. Major bleeding is if you have bleeding that cause death, we call it fatal bleeding, or a bleeding that cause drop hemoglobin more than 2 gram, or requirement of blood transfusion more than 2 units, or you have a critical site bleeding like intracranial, intra-abdominal, intramuscular compartment syndrome, retroperitoneal. This is, we call it major bleeding. If it's not the case, then there is other definition for clinically relevant. And what we care in the clinical trial is the major bleeding. This is ISTH, criteria for major bleeding. So we have the enrollment active cancer with symptomatic DVT and or BE, about 406 patient, is a smaller size than the Hokusai cancer. So they compare they compare the single drug approach, i.e. they use rivaroxaban from the initiation therapy. They use 15 milligram BID for 3 weeks or 21 days, followed by 20 milligram once daily, compared to deltabarine, the same, use 200 unit OD for the first 30 days, then 150 unit per kg after the first month. And they found, so for recurrent venous thromboembolism, there was about 60, almost, 55% reduction in the recurrence of venous thromboembolism. This is the rivaroxaban compared to deltabarine. And also the bleeding for major bleeding and clinically relevant non-major bleeding, we found there is also increase in the major bleeding compared to deltabarine. It was not significant, significantly higher major bleeding. But however, the same signal, it was, so this is continued for 6 months, but the same signal they found, the rate of esophageal and gastroesophageal bleeding was higher in patient with rivaroxaban compared to deltabarine. So again, it's the same, signal that patient with gastrointestinal malignancy, they have increased risk of major bleeding, in rivaroxaban and edoxaban. You can see this is the patient here, 11 patient with rivaroxaban compared to number 19 deltabarine, but the major bleeding, what we care, major bleeding is about 4. Here we have 1 major bleeding. Now we move to the Caravaggio study, or apixaban for treatment of cancer-related thrombosis, which is published a few weeks ago, was published exactly in Ramadan. And just to know, the Caravaggio study, Caravaggio is the name of Italian painter in 19, about like 200, 500 years ago. So they named the study based on this, Italian painter, and we know the primary investigator is he's from Italy. So apixaban for treatment of VTE associated cancer. So what's the background for this study? We know that VTE is a common cause of death and complication in patients with cancer, and the high risk of recurrent thromboembolism and bleeding in patients with cancer makes anticoagulant treatment challenging. So specific studies involving these patients are necessary. So this is unmet need, and major guidelines recommend the use of lumoxibirine for the treatment of cancer-associated VTE, and have recently added the use of edoxaban, rivaroxaban. So this is coming like after first trial Hokusai, then Select D for edoxaban and rivaroxaban. So that's why this is the very important point we'd like you to focus. The clinical benefit of this oral agent is limited by highest or higher risk of bleeding than with lumoxibirine, mainly occurring at GI sites or gastrointestinal sites. So that's why we'd like to test this, in this clinical trial. We know that apixaban has favorable, efficacy and safety profile in general population with VTE, like non-cancer patient. We have less GI bleeding compared to other drugs. That's why I would like, is it this reproducible in cat or not? So this is the trial design for Caravaggio. So objective to assess whether oral apixaban would be non-inferior. So remember, all the studies are non-inferiority to lumoxibirine. So non-inferior to subcutaneous deltabarine, which is along for the treatment for the prevention of recurrent VT in patients with cancer without increasing the risk of major bleeding. So we want effective drug as well as safe, because we have found in the previous drug they are effective, but the price is increased, risk of GI bleeding. And the patient population age more than 18, consecutive patient with a newly diagnosed symptomatic or incidentally discovered proximal lower limb DVT, whether it is located in the popliteal or a more proximal vein, or BE involving a segmental or more proximal pulmonary artery, any type of cancer other than, so they excluded basal cell or squamous cell carcinoma of the skin. I think these cancers, they have very low risk of thromboembolism and primary brain tumor, because or known intracerebral metastasis, they increase the risk of intracranial hemorrhage. That's why they did excluded these patients. And acute leukemia, we know leukemia patient is very difficult to manage, because they have severe pancytopenia, thrombocytopenia, platelet 10, sometimes 5. Okay, I know this is very cumbersome, very challenging. So this patient is different from other cancer, so excluded. So this is the reason why they excluded these patient. Then you have a multinational randomized control investigator initiated. So this is not industry initiated, this is investigator initiated, open label non-inferiority trial with a blinded adjudication of the study outcome, that we call a probe trial. So the number of patients, about 1,170 is large number. So this is the calculated sample size. It was powered, to reach statistical significance. They need about 800 plus patient, and they compensate for 20% loss of follow-up. So they inflated the number to 1,170. So they, randomized to apixaban 10 milligram BID for 7 days, followed by apixaban 5 milligram BID. This is the same protocol used with, other apixaban trial. And then you have the delta parin, the same protocol we have used before, 200 international unit per kg once daily for 1 month, followed by 150 unit per kg once daily for 5 months. So this is up to the trial continued for 6 months. It's very interesting you asking why all the previous trials, why they are open labeled, why they are not double blinded. I mean, the blind like the patient, blind from the patient and investigator. I think this is important, because remember we are using two different medication. We are using comparing oral with injectable medication. If you want to make a double blinded study, you need to give a placebo injectable medication for patient. So all these trials decided to make it open label, so they don't want to give placebo injectable medication. So it's open label, but for the adjudication committee, it's blinded. They don't know what are the patients. So this is the design. Primary outcome objectively confirmed recurrent VTE, proximal DVT of the lower limb, symptomatic or incidental symptomatic DVT of the upper limb, and BE symptomatic, incidental, or fatal, occurring during the first 6-month trial follow-up. And the principal safety outcome, the major bleeding ISTH definition, plus adding to it bleeding resulting in surgical intervention, and there are secondary outcomes. So this is already I talk about the key inclusion criteria, and this is the key exclusion criteria, like if the performance status, function status is a 3 or 4, we know this patient they're doing very poor. If the patient they have like palliative patient, they have life expectancy less than 6 months, they are excluded. If the patient receive either anticoagulant medication like VKA or lumefantrine or fondaparinux for more than 72 hours before randomization, they will be excluded. So these are the list of exclusion criteria. I will not go over them in detail. So this is the the flow chart for the enrollment of patients. So 1,170 patients underwent randomization. So about 50% assigned to receive apixaban, other 50%, about 585, were assigned to receive deltabarin. This is relatively bigger than edoxaban study. So this is the largest cancer largest trial to use DOACs and cancer Shet thrombosis. So patient day 9 did not receive the assigned treatment. So this is the patient they ultimately enrolled. About 576 were included in the intention to treat analysis, and this is 579 were included the same. So you have two groups. This is the details of the patient. Let's see the baseline characteristics. The baseline, demographic, clinical characteristics of the patient at baseline is they show they have balance of prognostic factor. You can see the age. So this is it means this is very effective, randomization for this patient. So you can very like equal prognostic factor, the age, the gender. You can find weight, etc. But important type of cancer is active cancer, about 97%. It's active cancer in apixaban and deltabarin, and most of them at enrollment they are receiving cancer treatment like chemotherapy, about 60% and about 63%. And this is also the performance status, because for oncologists this is important. They know that has very important impact. It's also balanced the echo performance status score. And types of cancer at baseline, you can see the colorectal cancer, about 20% in apixaban group and 19.5% deltabarin. It's almost equal. And you can see upper gastrointestinal, 23 patient, 31 here, about 5.4 and 4%. In addition to other, cancer sites. And what are the clinical outcomes during the trial period? So you can see this is the recurrent venous thromboembolism. In apixaban you have 32, and in deltabarin 46, like 7.9%, here 5.6. So there was almost about 40%, 37 to 40% reduction in the risk of recurrent venous thromboembolism, with a significant p-value for non-inferiority. So it was non-inferior. It met the objective, which is non-inferiority of apixaban to deltabarin, and showed it was not significant, but we call it here, this is what we call trend toward statistical significance. So it was not significant for superiority, but there was a trend for superiority. And also the major bleeding, you can see, I will go percentage 3.8 in apixaban and about 4 in deltabarin, and there was about reduction, about 12, 18% reduction of major bleeding. It was not, so there was no significant, increase in the major bleeding in apixaban compared to deltabarin. And interestingly, we found that event-free survival for apixaban about 73 compared to 68 in patient deltabarin. And if you can see that it can increase, 36% increase on, survival patient on apixaban compared to deltabarin. So this is the recurrent venous thromboembolism and major bleeding, and you can see this is the apixaban compared to deltabarin. As I mentioned, it was very, significant for non-inferiority. So significant p-value for non-inferiority. So it's non-inferior, and there was trend toward statistical significance for superiority. And you can see the curve started, to separate after 30 days. And you have the major bleeding also. The curves, they overlap with each other. And this is like there is no increase in the risk of major bleeding. And the results, deaths and causes of death at day 210. So about, you can see cause of death could be VT related, cancer patient, or could be due to bleeding, or cancer related, or cardiovascular and other. You can see the VT related about in apixaban 3%, in deltabarin 2.6%, bleeding like secondary to anticoagulant therapy, 1.5. Here it is 1.3. So it is almost, it's comparable, the cause of death for both arms. So most deaths were related to cancer, as you see, is not related to VT or bleeding. So vast majority of deaths related to cancer rather than VT or bleeding. And this is the, as I mentioned, the event-free survival. It was for apixaban 73 compared to deltabarin about 68. So this was significant, and can increase in the event-free survival. So this is forest plot for the recurrent VTE modified, and just to they break it down into age group, and they found like young, less than 65. So this is, if you see all of them, they cross the line of unity, but here age group, if the less than 65, you can this is, you can showing, favoring, apixaban for this patient. Otherwise, they are all of them, they overlap, in the line of unity. So this is just, if you break it like subgroup for all patient by age, by gender, by race. So this is advanced, statistical analysis for these patient. The same for major bleeding. You can see all crossing the line, there is no significance. What are the, also for anti-cancer drugs, for both group, you can see anti-metabolites. What chemotherapy used? This is maybe important for oncologist. So all they are, also they are fine, balance between two groups, zaltabarin and apixaban. You can find for all kind of anti-cancer drug therapy, whether it's anti-metabolite or platinum-based therapy or monoclonal antibodies. All these, they are equally, distributed for both groups. So what are types of outcomes contributing to primary safety outcome? Major bleeding. So for GI bleeding, so we have in apixaban 11 cases, and for deltabarin 10, and distributed upper about 5 and 6 here, and for lower 6, 5. So there is no, increased signal in GI bleeding with apixaban. This is important. Also, we don't find here for patient genitourinary or patient, because also genitourinary, it was just, it was not significant in this group, but there was a trend increase in genitourinary and bleeding. But the most important, GI bleeding, it was, equal or parallel. For clinically relevant non-major bleeding, it was also that we have 52, cases, 9% compared to 5.9. But this is the most important for us. The major bleeding, as I mentioned, for clinically relevant non-major bleeding is yet it's important, but it's less than major bleeding. So summary, this is the summary of adverse events, all adverse events in patients, serious adverse event. You can see also between two groups, adverse event that cause study drug discontinuation. You can see the percentage is equal between the two groups. So what's the limitation of this study? It was an open label trial to avoid the use of parenteral placebo. So we don't want to use parenteral, placebo for 6 months for this patient. It really is a burdensome for this patient. So that's why all these, drug trial in cancer, they use open label, they use a probe open label, but they have blind, adjudication for the end point or outcomes. And GI bleeding was not a pre-specified trial outcome. However, after the publication of results of studies of other direct anticoagulants such as bleeding, such bleeding emerged as a relevant safety outcome, from Hokusai and SELECT-D, and patients with the brain tumor, non-cerebral metastasis, or acute leukemia were not enrolled for safety reasons because they increase the risk of bleeding. So the results cannot be extrapolated to this patient population. So you cannot use, you have to use, the standard of care lumoxitibarine for this patient. As in the large majority of studies regarding the treatment of VTE, the sample size of the trial was powered for the primary outcome, recurrent VTE, and was not powered to make definitive conclusion about bleeding. So just to compare both things together, remember these, I mean, the three studies, Caravaggio, Hokusai, VTE cancer, and SELECT-D, they are not, head-to-head comparison. They are different studies. We try just to put them in table to compare. So they are no adequate and well-controlled head-to-head clinical trial comparing the efficacy and safety. So they are different because they have different inclusion, exclusion criteria. So the patient population is, different, or enrolled, participant different. So here, if you find, as I said, this as Caravaggio is size-wise, it's very large, is the largest one, followed by Hokusai. It is, similar, I mean, close to it. And we have the smallest one is SELECT-D. And you can see again the same for it is telling you that Caravaggio, including the patient population, is high risk. So see metastatic disease about 67, 68. Here about metastatic disease 52 in Hokusai VTE cancer, and 58 in SELECT-D. So remember, so this is, yeah, you cannot doubt the result. I mean, the patient is really high risk, cancer population, active chemotherapy. So it is, again, it is high, 85%. I mean, 85% in apixaban. Can he 71? This is, yes, at about 81, close to it. GI cancer, you can see the colorectal cancer 21. And upper like esophageal gastric about 4%. You can hear it's about 15 and 27. So it is almost like in SELECT-D and Caravaggio, they have the highest number of GI tumors. So this is just to focus about functional status, echo, and all they are, I mean, like similar. So this is what I found, slight differences, and also the major GI bleeding. You can see Caravaggio about 1 point oral agent for, I mean, delta bari for apixaban 1.9%, for delta bari 1.7. You can see here for apixaban Hokusai 3.8%, and for SELECT-D it is 3.9%. So it is, if you compare, remember they are not head-to-head comparison. Okay, it's different clinical trial, but you can see really there is a difference between the three studies. Now talking about the guidelines. So we have, recently published ASCO, or American Society of Clinical Oncology Guideline 2000, around maybe October or December 2019. It's recently published for prophylaxis and treatment in oncology patient. I focus about treatment here. And we have the European Society Guideline 2019, treatment of PE in patient with cancer. And we have the Saudi Clinical Practice Guideline published 2015. Definitely published 2015. We don't have this clinical trial of drugs, so it was focused mainly on low molecular heparin. Hopefully, we are in Saudi Arabia as organizing. Preparing for clinical practice guideline for cancer-associated thrombosis to be published in 2020, inshallah. So talking about the American Society of Clinical Oncology guideline, published in August 2019. What's the best method for treatment of patient with cancer with established VTE to prevent recurrence? So the initial anticoagulation may involve low-molecular heparin, unfractional heparin, fondaparinux, or rivaroxaban. And this is both, I mean, this guideline published, after the SELECT-D and Hokusai VTE cancer. So low-molecular heparin is preferred over unfractional heparin for the initial 5-10 days of anticoagulation for the cancer patient with the newly diagnosed VTE who does not have severe impairment, because we know the advantage of low-molecular heparin over unfractionated, because less risk of hurt, less bleeding. And for long-term anticoagulation, low-molecular heparin, edoxaban, or rivaroxaban for at least 6 months are preferred because of improves efficacy over PK. Remember here they did not add, initiation edoxaban because remember edoxaban, the clinical trial design, it is not used as single drug approach. It's used after lumoxifene for 5 days. Then they switch to edoxaban. That's why only included in the maintenance phase, but not included in the initiation phase. So VKAs or vitamin K antagonists are inferior, but may be used in if lumoxifene or DOACs are not accessible, because some patients in poor area, countries, so they might have only vitamin K antagonist. They cannot afford DOACs or lumoxifene. There is an increase in major bleeding risk with DOACs, particularly observed in GI and potentially genitourinary malignancy. Remember, this is before Caravaggio, these guidelines published. Maybe the guideline, next, version, they will change based on the new data. Caution with DOACs is also warranted in other settings with high risk for mucosal bleeding. Drug-drug interaction should be checked prior to using a DOAC. This is very important. Anticoagulation with lumoxifene, DOACs, or VKA beyond the initial 6 months should be offered to select patients with active cancer, such as those with metastatic disease or those who receive chemotherapy. So we know the duration of treatment of cancer-associated thrombosis is for 6 months. If the cancer is cured, but if the cancer is not cured, like metastatic, uncurable, so the treatment should be extended, indefinitely. They recommend against the insertion of vena cava filter. It is only indicated for patients with contraindication to anticoagulation. If the patient is bleeding, you cannot anticoagulate, or developed complication of anticoagulation like bleeding, then you need to insert IVC filter, but should not be inserted routinely, okay, or as a prophylaxis. It may be considered as an adjuvant to anticoagulation in patients with progression of thrombosis. I have one patient failed DUAC, failed lumoxifene. Then we increased the lumoxifene from the therapeutic dose to supratherapeutic dose, and we checked anti-10A to make sure anti-10A level to be 1.5. In addition, we inserted IVC filter. So some patient you can use IVC filter as adjuvant, but not as mainstay treatment. So for patients with a primary or metastatic CNS malignancy and established VTE, anticoagulation as described for other patients with cancer should be offered, although uncertainties remain about choice of anticoagulant. So this is very important area, of clinical equipoise. Careful monitoring is necessary to limit the risk of hemorrhagic transformation for this patient or hemorrhagic complication. Use of rivaroxaban and dexaban have been added as options for VTE treatment. So based on consensus, this is important. What you need to do for patient with incidental PA, like patient present with cancer, and you perform staging CT, and you found incidental asymptomatic PE or incidental asymptomatic DVT. Should you treat? They should be treated in the same manner as symptomatic VTE, given their similar clinical outcomes compared with patient without cancer, with cancer without symptomatic. So they should be the guideline. They recommend treatment of this patient. Also important, treatment of isolated subsegmental PE, or like isolated subsegmental PE. It's sometimes we just go with the clinical surveillance without anticoagulation. But if you have subsegmental PE with cancer, they should be treated. This is cancer is high risk, considered high risk for recurrence, high risk for progression of DVT or propagation to pulmonary embolism. So you need to treat subsegmental PE, or splanchnic or visceral vein thrombosis diagnosed incidentally should be offered on a case-by-case basis. So this is a case-by-case basis, like if, for example, like incidental portal vein thrombosis, incidental chronic portal vein thrombosis, I will not anticoagulate. That's why case by case basis. If you have a subsegmental BE for this patient, no, subsegmental BE, if a patient is young, have it might cause a recurrence for this patient, I will anticoagulate this patient. So that's why case by case basis. That's why you have to consult the expert you consider potential benefit and risk of anticoagulation. So what are the contraindications to therapeutic anticoagulation in cancer? Remember, I'm just talking about the ASCO guideline 2019. What are the contraindication, absolute contraindication in cancer patient with VTE? This is pertaining to DUACs and non-DUACs. So active, major, serious, or potential life-threatening bleeding, not reversible with medical or surgical intervention, including but not limited to any active bleeding in a critical site like intracranial. If you have severe uncontrolled malignant hypertension, severe uncontrolled coagulopathy like liver failure, persistent severe thrombocytopenia. Here they really absolute contraindication for cancer patient less than 20%. This is absolute contraindication, and less than 50, it's a relative contraindication. This is based on the guideline. Actually, the cutoff really we worry for us at thrombosis less than 50. We really worry about it if it is less than 50. But maybe cancer patient is a different population. That's why the guideline here they went with less platelet count 20. High-risk invasive procedure in critical site, including but not limited to lumbar puncture, spinal anesthesia, epidural, all these absolute contraindication. So this is DUAC specific. The other like DUAC and non-DUAC. For DUAC specific, if you have concurrent use of P-glycoprotein or CYP3A4 inhibitor or inducer, and there is like antifungal treatment like itraconazole, and if you have antibiotic like rifampicin, also antiviral drug. There are some anti-rejection drugs, cyclosporine, etc. So these are the main, what we call P-glycoprotein CYP3A4 inducer inhibitor. What are relative indications? These are relative contraindications, like intracranial or spinal lesion at a high risk of bleeding, active GI ulceration at high risk of bleeding. So this is active ulcer, but high risk for bleeding is not bleeding. Active but non-life threatening. Example, trace hematuria, recent high bleeding, and the platelet here, they persistent thrombocytopenia 50,000. So less than 50, this is relative contraindication. The safe cut, point more than 50. With our colleague, hemato-oncologist, they use anticoagulation, for less than platelet less than 50. Some of them up to 25. So what are patients for whom anticoagulation of uncertain benefit in cancer patient? If the patient receiving end of life or hospice care, or very limited life expectancy with no palliative or symptom reduction benefit, asymptomatic thrombosis with concomitant high risk for cyst bleeding. So as I mentioned, if the patient having subsegmental BE or incidental portal vein thrombosis with active bleeding or high risk for bleeding, I will not use anticoagulation because the risk is outweighing the benefit. Refusal or preference of the patient, non-adherence to dosing schedule, follow-up or monitoring. So now talking about, this is briefly European Society of Cardiology guideline. This is for management or treatment of BE in cancer patient. So they added, in the recommendation for regime and duration of anticoagulation after pulmonary embolism in patient with active cancer, they added that edoxaban should be considered as an alternative to weight-adjusted subcutaneous low molecular weight heparin in patients without GI bleeding. So this is based on the HOCOSI and SELECT-D. And rivaroxaban should be considered as an alternative to weight-adjusted subcutaneous low molecular heparin in patients without GI bleeding. So they added here, so we can have options here that DUACs also part of the cancer-associated thrombosis in European Society Cardiology guidelines. And this is the prophylaxis and treatment of VTE in patients with cancer, Saudi Clinical Practice Guideline, published 2015. You will not have any mention about DUACs because this is considered to be old guide, hopefully waiting for the new guideline in 2020 or 2021. Just to wrap up and summarize, starting by Caravaggio study, it's the favorable, safety profile found for apixaban is in agreement with the result of previous randomized trials. of this drug with respect to the treatment of VTE in the general population. Like they're talking about Amplify study and Amplify extension. Also, the findings may expand the proportion of patients with both cancer and be eligible for treatment with apixaban, including patients with GI cancer. So you might see the guideline, there is modification in the upcoming guidelines. And oral apixaban was non-inferior to dalteparin for treatment of cancer-associated thrombosis without an increased risk of major bleeding. And so far, you need some time, to change the clinical practice. Still, lumoxitibarine remains the treatment of choice for patients in whom like DOACs cannot be given. Individualized approach based on risk of bleeding versus recurrence and incorporating patient preference. And for cancer patients with a new VTE and they have low risk of bleeding and no drug-drug interaction with current systemic chemotherapy, treat with DOACs. And if you have cancer patient with a new VTE and high risk of bleeding, treat with lumoxitibarine. And usually this is like a patient recently diagnosed with VTE during hospitalization. Sometimes you need invasive procedure, patient with chemotherapy, they have severe. I think these patients, initially, safely to be treated with lumoxitibarine, but upon discharge they can be discharged on DOAC. And the patient high risk bleeding include patient with luminal GI cancers with an intact primary, cancers at risk of bleeding from genitourinary tract, bladder, or nephrostomy tube. I have seen these patients nephrostomy tube. They really have high risk for bleeding, or patient with active GI mucosal abnormalities such as duodenal ulcer, gastritis, esophagitis, or colitis. With this, I will end up my presentation and will open the floor for question. Thank you for your concentration.
So moving to the next question, Dr.sheef, would you think that the Caravaggio study will change the current guidelines and include apixaban to rivaroxaban and edoxaban in cancer-associated thrombosis management?
Yes, I just mentioned in my conclusion. I think, based on the Caravaggio study, the guideline will be, modified. So they will not, mention that you have to use it with in patients with GI cancer. I think based on the study, it can be used safely with GI cancer with excellent efficacy and safety profile.
Thank you. The second question related to the exclusion criteria. They excluded patients with or who are on cytochrome inducers. Does this explain the lower bleeding complication?
No, I mean this is like excluded in all other DOAC trials for apixaban, like Amplify, or for Einstein, DVT, BE, Einstein chose, or there is significant interaction with the B glycoprotein inhibitor inducer and also cytochrome, I think B4A inhibitor inducer. So there is interaction between these medications. So they excluded this medication.
Yes, and if I may comment, I would say thank you, Dr. Muhammad, of course, that the cytochrome, the strong inducers of cytochrome B450, 3E form might increase the elimination rate of the medication, reducing their bioavailability, putting the patient at higher risk for thrombosis. That's why they were excluded, and they are generally excluded or not recommended to be used with NOACs as per the label recommendation. And the same for apixaban as well. That's why they were excluded from the study. Thank you, Dr. Muhammad. The next question is about, is there any data about renal function in the study?
For Caravaggio?
Yes, Caravaggio.
I did not come across it, but they excluded even the exclusion criteria. If they have severe renal insufficiency, whether they excluded less than 30 or 15 maybe Yasin, but they excluded patient with either severe renal insufficiency or very severe renal insufficiency.
Yes,
So they
thank
were
you.
excluded.
Yes. Any patient showing deterioration in their renal function were excluded or withdrawn from the study. In addition, 90% of the patients were with no or mild renal impairment, just less than 10% of the patients with moderate or severe, mostly will be just moderate renal impairment. And it was very minimal due to the complications of the complexity in such patients. Another question related to the kind of patients that the doctor should use the prophylaxis with anticoagulant. I think you've covered this, Dr. Muhammad, in the closing about the recommendations for which patients who are eligible for anticoagulation. But if you would like to comment on that.
So can you, repeat the question?
Yeah, the question related to which cancer patients should the doctor use the anticoagulation prophylaxis?
Like cancer patient, cancer-associated thrombosis.
Yes. Yes.
Yeah. So cancer-associated thrombosis should receive a treatment. Should not be a prophylaxis, so therapeutic anticoagulation. And which one to use, DUAC or lumoxitiprine? Now with the new clinical trials, you can use DUAC. DUAC is not non-inferior to lumoxitiprine, although still the lumoxitiprine is the standard of care. Based on the most recent guidelines. And as I said, if you have a patient with high risk features for bleeding, severe thrombocytopenia, inpatient, you might expect, invasive procedure. It's better to use lumoxitiprine in the stormy acute phase. Then you can switch to DUAC and use it for, let's say, 5 or up to 6 months, because treatment of cancer thrombosis should complete the course of 6 months. If it is cured, if it is uncured, it can be extended beyond. So it's really this area. It's left for physician discretion, their clinical judgment, which to use. But as inpatient, I discussed with my oncologist, colleague, hemato-oncologist. If the patient high risk for bleeding, they use lumoxitiprine. If it is less risk of bleeding, like most of our patients in the clinic right now, they come to our clinic if they have cancer thrombosis, they are in DUACs. Like we initiate inpatient lumoxitiprine, but outpatient we use DUACs, and already it is approved and recommended by the clinical practice guideline.
Thank you. And actually, the next question was about the duration of apixaban or DUACs used for such patients. So I think you have already covered it, Dr. Muhammad.
Yes, it should be, must be 6 months. And the guideline they mentioned, all the clinical trial, the duration up to 6 months, but it can be extended beyond 6 months if you have a cancer that is metastatic, uncured, can be extended. But there is no any guidance if we can use low dose DUAC in this patient after 6 months. I don't think so, because this population is higher risk of thrombosis compared to non-cancer patient. I don't recommend to use low dose DUAC for these patient, and there is no guidance or recommendation for it.
Thank you. Another question about a case with a doctor, patient on apixaban and started to have GI bleeding. What to do with this patient? Stop apixaban?
Yeah, definitely. If a patient on any anticoagulant therapy and develop bleeding, so you have to classify this bleeding. Is it a major bleeding, as I mentioned, meeting the definition or criteria for major bleeding, like causing drop hemoglobin more than 2 gram, or requiring blood transfusion, or in a critical site, or causing death. So this is important. So you have to discontinue anticoagulation and you reverse the drug. Yes, it is a short half-life, 12 hours, but you need to use, a reversal agent. Like we don't have direct antidote in Saudi Arabia. Yes, it is approved by American FDA and Dixonate Alpha, but we have in Saudi Arabia direct, prothrombin complex concentrate (PCC). So also prothrombin complex concentrate. It was proven, efficacy about 70% success rate in reversal of bleeding. So I don't recommend to stop like just mild nosebleed or gum bleed or mild hematuria. So you have to be careful. If it is major bleeding, I will stop. If it is clinically relevant in major bleeding, I might, stop one day and observe what's the cause. Maybe there is underlying, cause for the bleeding. Many times, sometimes it is, we do see, combined antiplatelet, anticoagulant therapy. We stop aspirin, for example. So we have to be case by case basis, make sure that the patient is not doubling the dose, is not taking other antiplatelet medication, can potentiate the effect of, anticoagulant or apixaban.
Thank you. The next question, any dosage adjustment required in moderate to severe cancer cases?
Moderate, so the dose is not,
cancer.
Yeah. The dose is for apixaban is no adjustment, is 5 milligram, 10 milligram for the first 10 milligram BID for the first 7 days, then 5 milligram BID. I have seen physicians, they adjust apixaban, they give 7.5 BID. It's not, this is off-label use. This is not approved. No need. This is the advantage of these drugs. They don't need adjustment. These are fixed dosage. You have fixed dose in the initiation and fixed dose in the maintenance medication. Only you need adjust if you have renal impairment. That's different case scenario. But I have seen if you have failure, you don't need to, increase the dose or to 7.5 or 10 milligrams. So this is the dosage of the drug. Only the adjustment if you have renal insufficiency, because it's renally excreted about 27%.
The next question, is it mandatory to start the treatment? The doctor means antithrombotic prophylactic therapy in patients diagnosed with carcinoma?
No, the guideline. So you have two different groups. You have inpatient cancer patient, and you have ambulatory cancer patient. So all the guidelines, they recommend, standard routine VTE prophylaxis. This is the standard of care. So all hospitalized patients. So for ambulatory cancer patient, there is emerging data. Some ambulatory cancer patient, they put on a prophylaxis, like patient multiple myeloma. They are using some, chemotherapy, thalidomide or lenalidomide. Some cancer patient, if they have indwelling, venous catheter, they put. So the guideline is evolving. So ambulatory cancer patient, yes, some of patients, they can receive VTE prophylaxis as a primary without VTE, but for inpatient, it's a standard of care. Should not deviate from it. All hospitalized cancer patients should receive VTE prophylaxis as a routine practice. For ambulatory cancer patient, if you review the guideline, ambulatory cancer patient, some of them, even like we discussed in our guideline 2015. I'm just privileged to be one of the author. So if you review it, there you will find ambulatory cancer patient, subset of patient, we put them on prophylaxis, extended prophylaxis. So ambulatory cancer patient.
Yes. Thank you, Dr. Muhammad. And actually, it was the last question. We appreciate your time and support to address all these questions. And thanks again for the informative presentation and keeping us well informed and updated and building our experience in the field of management of cancer-associated thrombosis. We are looking forward to having more and more sessions on the subject. It's very important, and it of clinical importance to many doctors, especially with the evolution of these important clinical data. So thank you again, and we would like also to thank the doctors who joined us for tonight's webinar. Appreciate their attendance, their time, and attention alongside the webinar. Thank you so much, and we are looking forward to more educational webinars to come. And Dr. Muhammad, if you'd like to close with one or two words to our doctors.
Thank you, Faisal. Thank you, dear, attendants, for your attention, for being, saving your precious time for more than 1 hour. Really highly appreciated. I'm very grateful for you, and hopefully to see you, soon other webinar. Thank you very much.
Thank you, Dr. Muhammad. Thank you, and see you next time, inshallah. Assalamu alaikum.
Alaikum salam.